Now, we can very much get the drug to the tumor if we shoot a vaccine into it, or if we give a vaccine. So can you tell me, Gavi, there's some locally advanced vaccine data that's coming through?
Yeah, so obviously the field of immune therapies is one of the most appealing in many malignancies, and obviously we're interested to see whether it applies or not to pancreatic cancer. In the field of immune therapies, Newlink Genetics has developed an hyperacute vaccine. Basically is cell lines transduced with alpha-galactosidase, which is a gene that doesn't exist in humans. It exists in murine models, and therefore it's expected that our human body reacts by producing an immune argument against it. So originally they started with adjuvant. Basically, patients that had resected pancreatic cancer were treated with standard chemotherapy plus minus radiation plus minus a vaccine. And at ASCO 2012 and 2013, we heard that there is a fairly promising improvement in disease-free survival. Preliminary data has already been published about a year ago. But what we found out very interestingly is that survival could double from 24 to 42 months for patients that actually develop an immune reaction, especially an anti-mesothelin antibody to the vaccine. And based on this promising data, we now have a locally advanced pancreatic cancer study where patients are treated with either a backbone of FOLFIRINOX or gemcitabine nab-paclitaxel, with or without radiation, but mostly with or without the vaccine to really prove whether the vaccine might be beneficial in the locally advanced setting. So contrary to other studies that started metastatic disease and they fail and then we never get to know whether they would ever work early in the disease stage, this vaccine developed from early stage to more advanced disease to know whether it can prevent metastatic progression. I think it's a very important study. It's an international or at least national study, large number of patients. So we are very much anticipating the results. And of course, we all hear about, more vaccines from the vaccine groups at Johns Hopkins and Memorial and other places. And immune therapies, again, we are really hopeful that in the right combinations may have a role in pancreatic cancer.
That's excellent. And there is one place in pancreas cancer where genetics may play a very significant role, and that's the BRCA patients. So Francis, BRCA mutations, BRCA2 mutations, pancreas cancer, what are your thoughts there?
Well, I think we opened up a new can of worms. And I think, everyone knows about BRCA 1 and 2 and the breast-ovarian connection, but it's only been in the last few years that we kind of realized there's a lot more to this. And one of the things that you made an example of the 43-year-old mom that comes in with the puppy and the children and all that. And the first thing I say to myself is, why is a 43-year-old getting this disease? And I think we really have to take a look at this. I think we're realizing that BRCA positivity is not just restricted to very select groups of patients. When we originally looked at BRCA positivity, it was in the Ashkenazi Jewish ladies. That was going to be our first clue about this disease. But now, things have opened up. Routinely, if a person comes into an office that has breast cancer, if a lady has breast cancer who's under the age of 45, we're looking for BRCA positivity. We just found out this past year from the University of Chicago the high incidence in African American women that have breast cancer, that the incidence is maybe as high as 20 or 23% with BRCA positivity. So we're opening up this can of worms of genetics, of who is a part of it, and the fabric of different cancers that are part of the BRCA syndromes. So I think we're making some ideas why that 43-year-old mom might have had that cancer. And I think we're still looking, and I think this is a really exciting time for that.
Yeah, and there's also the PARP inhibitors that not only are being looked at for BRCA positive breast cancer, but also in pancreas cancer. So exciting, so much happening now in the field. It's almost like a renaissance per se. And then we have here, we're at beautiful San Francisco. Don't be jealous, it's 75 degrees here and sunny, but we're inside here. We saw a few interesting abstracts, and the first one I'm going to ask Ramesh to comment on. This is, it's not actually, I'm going to have you talk about yours. We're looking at metabolic response to treatment.
This is data from the phase 3 IMPACT study. Out of the 862 patients that were randomized, the first 250 patients had serial PET scans. And they had PET scans at baseline, 8 weeks and 16 weeks. And what we found looking at the data is that the PET response by the EORTC criteria was double that of the CAT scan response. And patients who had a PET response, very few complete, but mostly partial responses, had a much better outcome than those who didn't. So we think this may be something that can be used. It certainly seems more sensitive than CAT scans. Interestingly, there were a group of patients where CAT scan showed progression, but the PET scan showed a response, or mostly a response. And in that subgroup, the survival actually seemed to be fairly reasonable, better than those who had progressed, certainly better than gemcitabine alone. So we think this is something worth pursuing, and PET scans should look at it even in early the stage of treatment, perhaps at 4 weeks or even 2 weeks, whether to see a new regimen is working.
And we're going to Hodgkin's disease then.
Right, exactly.
In Hodgkin's disease, you want to get it after the first cycle, second cycle, and if they're a winner, continue. If not, get ready for a trial.
I think that's where we should be going.
You're going to have everybody on the phone with insurance companies, so maybe not quite prime time
Not
but
yet,
very,
but
very exciting.
for clinical trials and a research question, certainly.
Very, very exciting.